It gives me great pleasure and honor to perform this, the privilege of really selecting and giving the Lifetime Achievement Award. And our 2025 Heart Valve Society Lifetime Achievement Award goes to Dr. David Adams. All of you know Dr. Adams, but let me give you a brief overview of his career. Dr. Adams was born in North Carolina. His father was a veteran and a physician at Duke. He has two brothers, and you can see that from a very early age, you can see in his eyes that little aha moment that we were talking about earlier today. He followed on to go into medical school, an undergrad in medical school at Duke University, where he graduated from, and then followed that with training at Brigham with Dr. Larry Cohn. He actually spent 6 months during his fellowship with Professor Yacoub in London. At the time, his interest was in lung transplantation, and he actually holds a couple of patents into transplant medicine and even homograft preparation. But his real interest was harnessed and developed under the tutelage of Professor Carpentier in mitral valve reconstruction, where he spent many visits in Paris and eventually developed a very close transatlantic collaboration with Professor Carpentier, himself coming to Sinai and Dr. Adams going to Paris multiple times. They wrote what is the most sold textbook in our field, the reconstructive valve surgery textbook. And really, mitral surgery became his passion, his calling, and I don't think many people in our field, other than Carpentier himself, have really impacted the field of mitral valve repair the way he did. He developed the mitral conclave, which has now become a household name in our field in 2011. Over 1,000 participants have been going on every other year to New York to participate in the conclave. It is now into its 8th edition this coming December, with just as much enthusiasm and participation from surgeons from all over the world. He has been very proactive in teaching the techniques. He's been a pioneer in terms of video libraries, of demonstrating the operations, and really teaching all of us who have an interest in mitral surgery the principles, the commitment to detail, the analysis of the valve, and how to achieve excellent results. And he's been very generous with his time, traveling the world in over 50 countries. You can see here on one of his trips to China, demonstrating mitral valve repair techniques. This is the foundational years, the picture with Professor Carpentier, repairing mitral valves, and all of the culmination of all of this was himself being the 99th president of the American Association for Thoracic Surgeons back in 2019. But really, I know him more not just for his accomplishments, but over the last 5 years as a colleague, a mentor, and I can fairly say a friend. He is someone who cares deeply about patients and not just about the operation or about the podium. You will see it in each and every one of the patients that he treats. He spends at least 45 minutes seeing them, caring after them, following them, and for that, I think he is far more than just an exceptional surgeon or a true academic or a fantastic teacher. He really is a great mentor to me and to many others in our department and across the world. So, Dr. Adams, without any further ado, please come up to the stage. We have a little token to.
Thank you very much. That's awesome.
All right. Thanks.
Thank you. Ishmael, thank you very much. What a privilege to be here today. You know, I remember for some of you young people coming to one of the original Society of Heart Valve Disease meeting back very early in my journey as a young trainee in cardiac surgery. And it just shows you again that word that we heard this morning from Ishmael about hard work. and being lucky and mentorship and trying to take advantage of opportunities, what can happen. So thank you very much. I made a mistake on my first slide already. I wanted to have it say David L. Adams, because as you notice, two of my partners, Ahmed El Ishmawi and Ishmael El Hamamsi, I just want to be the third Egyptian now in my department after this lovely visit to Cairo. At any rate, for this discussion, I wanted to focus on an old disease that's getting new attention, and that's arrhythmic mitral valve prolapse. And it's such an important topic, and I think it really summarizes a lot of why this society exists today. What happens when multidisciplinary teams that are dedicated to valvular heart disease all get together and study things. And before I do that, you cannot get any kind of achievement award or thing like this without talking about mentors, which is exactly the message that Ishmael gave you today. And here are the individuals that Dr. Sabiston, who was my aha moment when I was a college student volunteering as a scrub nurse in urology to prove that I wanted to be in a hospital. And I saw him do a coronary bypass, and that was the day I called my mom in North Carolina and said, I'm going to be a heart surgeon. Larry Cohn in the middle above, he was the teacher of our residency program and the chief that I trained under. Aldo Castaneda, I also trained under and became a very close friend of mine and actually a patient of mine, which was probably one of the greatest honors of my career, was to actually do his mitral valve. And of course, Magda Yakub, where I also had the privilege of doing a fellowship. Ishmael mentioned the relationship with Elaine Carpentier, which I can't have to say before I start talking about the topic at hand, which was really my most important mentor, not only in terms of giving me a foundational understanding of valve reconstruction and the privilege of writing this book together with him, but reinforcing perhaps more than anyone else the role of being a doctor. And do you see the theme? How did Ishmael talk today about Yakub, about his technical skills and his commitment to work, and then his compassion at the bedside? And the second person, and remember, they were very close friends, incredible mutual respect between Carpentier and Yakub, and he was the same way. It wasn't just his fame and intellect, but it was his just complete dedication to patients and how kind he was in every aspect and everyone that he interacted with in a hospital, and it was something that I always took with me. Now, on to the topic at hand. This is an old topic. Arrhythmic prolapse is the original description by Barlow. Before there was echocardiography, there was a recognition of systolic clicks and premature ventricular contractions. I mean, imagine that. It's not a new disease. It's an incredibly old disease, and so much progress has happened now from it. But in the beginning, it was just recognizing that patients that had mitral valve prolapse, particularly a certain phenotype, women with bileaflet prolapse, were at risk for sudden death. And this was one of the original descriptions of this from a private practice cardiac surgeon in Connecticut that noticed this incidence of death associated with mitral valve disease. And of course, I'm going to fast forward because we don't have time in 15 or 18 minutes to talk about all of the incredible literature now that's starting to accumulate. But I will highlight a few, and I'll show you a little bit of our own work. This paper was very important. It was published in the Mayo Clinic. Clinics like the Mayo Clinic can have a clinic for people that survive sudden cardiac death. Can you imagine? The way you get in the clinic is you have to die in the field and be resuscitated. But that's what this clinic was. And when they looked at their patients, they saw this exact same sort of phenotype present itself. They were predominantly women, predominantly younger, predominantly bileaflet prolapse, and had inferior infarct patterns. They had something going on with their papillary muscles. So this phenotype starts to emerge again from Barlow to the Mayo Clinic. And this particular study was a very important one from Basso from Italy. And she started to do the autopsy studies. Now we've had other ones, and I don't have time to show all of them. But this particular autopsy study began the linkage of patients that had sudden cardiac death and myxomatous valve disease, and importantly, scar in the ventricle. So now there was starting to be this linkage, and I'll just plant that seed with you. Remember, we talk a lot about the ventricle can affect mitral valve performance, right? Carpentier type 3B dysfunction. Your ventricle dilates, your leaflets get pulled open. This was the beginning of the next question. Can mitral valve anatomy impact your ventricle? The opposite. And I think the answer is true. What she found was this linkage of fibrosis and bileaflet prolapse, but also, and it's unusual, you would never see this today, by the way. When was this, 2015? We got 2 papers in one. Now you'd get 4 papers. She'd divide this data into 4 papers, but this time she presented both papers in the same data set. She showed the pathology, then she showed where she went from there. She looked at patients that were alive, and she looked at their anatomy, and she brought in this idea of looking for MRI enhancement to identify scar. And the same thing she saw, patients that had ventricular ectopy were more likely to have scar. So now these linkages were starting to become more important. And then as we progressed, now the next paper from this group talked about mitral annular disjunction, and we had this discussion yesterday. Mark gave a very good talk about it, about the annular disjunction and the role of that in this disease process, and I actually think it's more of a along for the ride. Yes, patients that have mitral annular disjunction have an increased incidence of scar, fibrosis, and arrhythmias. The question is that the culprit, or is that just along for the ride? Because I'll remind you of this figure that of the differentiation of valve disease. We've been very interested in this. We originally drew this figure not for days like today, but really to try and give surgeons a framework of how to think about valve reconstruction. So each one of these categories, whether it's FED or you have a little more prolapse or you go to the other extreme of Barlow's disease, how you think about reconstructive strategies and how you think about resections and amount of tissue and things like that. But here, it also brings up the point of leaflet height, volume, and mitral annular disjunction, which as you move toward the Barlow side of this figure, all of those are much more common. Why does that matter? Because this is the theory. If I want to go fast, if I want to create tension, I put a big sail on a boat, right? If I want to have a leisurely trip, I have a small sail. The same is true in the mitral valve anatomy. I think this is one of the fundamental things most investigators, many of whom are in this audience, believe today, that mitral valve anatomy and the tension that bileaflet prolapse or large leaflet segments or annular disjunction, all of that together can help create, is probably the culmination of what happens in terms of stretch and creating this phenomena. Again, when you look at fibrosis in patients, it's so important to remember that most patients that have, many patients that have arrhythmias have fibrosis. And this is scar. This is the fibrosis that you can see the end stage. And I think it's also important to remember that it will start earlier than just fibrosis. And I showed this paper and because I think it's really important to remember that if we did it backwards this time. We actually, and this paper is so neat, it's from Bob Levine. It's from Bob Levine's group. He was the involved. It was really important. Mike Borger participated in this. This was a knockout mouse study that created basically a Barlow type valve in mice. And guess what? They found the exact same thing that has been shown in humans, and that is that it was if you give mice the same sort of tension and pull on leaflets, not chordal rupture, but chordal elongation, they create fibrosis. So fibrosis is really, really, really important. And I think we're starting to get the hang of this, and many more other investigators now have advanced our knowledge of that. But because of the limitation of time, I can't show all those papers. What I will show is a little bit about our own journey in this. I honestly was not aware of this disease. I sort of grew up in the group that was told PVCs, you don't really worry about them very much in mitral valve disease. And it wasn't until 2017 that I actually started to even become familiar with this literature. And I think there's a message there again for young people. These problems, you'll never come up with an original idea. Remember that. Make sure you go to the stacks. Someone else has observed something in mankind. However, you can take it to the next level, and it's really important. And then you can also learn new things, and then that can stimulate you. This is how we got stimulated in this field. We were putting a patient to sleep that had bileaflet prolapse. It was a routine case. She was asymptomatic. She had some PVCs. Her only medical history was she remembers that 30 years ago, she had some instability when she got put to sleep for an obstetric procedure, but that was it. Nothing else. We didn't think anything of it. That was her echocardiogram. Typical, you wouldn't think anything of that. Ventricle, that was her pre-op EKG. She had some PVCs. Again, we didn't think anything of it. She was going to sleep in her room. I was finishing up in another room, and they called me and they said this happened. They induced her, and she went into ventricular arrest. I remember saying, I don't think I've ever heard of that before. I went back, they'd done CPR, they cardioverted her, and that was her ejection fraction now. Same patient I showed the echo preoperatively. Now she has an ejection fraction of 10%, having complex PVCs. Needless to say, that got all of our attentions. I called the EP, Dr. Mark Miller, who you'll see some of his papers, to the OR, and that also formed another partnership. Sometimes partnerships happen under the unseen circumstances, but she got resuscitated. He looked, he saw these polymorphic BPs. He guessed it was a papillary muscle urge, and we put a balloon pump in. She got better. We did an MRI post-op. She had scar, and basically what we did was we put an ICD placement in, and we sent her home. It took took the patient and myself both about 6 months to get the courage to do the valve repair, which we eventually did. But this is how we started to get interested in this disease. It's interesting, isn't it? You start with a patient. Like we're doctors, we start with a patient. But then we need a big tent if we're really going to solve this disease process. And what I wanted to show you was a few more patients, real patients, and it helps explain our journey. This was one of the next early patients that we saw. She was 44. She was an athletic person, much like the patient we showed yesterday in the breakout, Congressman Barrett's wife, that had died suddenly on a Zoom call. Doing well, having palpitations, ejection fractions, borderline, very asymptomatic, being followed for years and years, active surveillance. That was her Holter PVCs. 2 morphologies, no one's commenting. Again, being told to be followed. That was her surveillance sort of TTE. And you see this pickle hop sign. This is this rapid movement of the posterior annulus, this displacement. Otherwise, and by the way, that's not a lot of MR, is it? It's mid-systolic. It can be severe when she exercises. That's the pickle hop sign, this displacement or this spike, again caused by mitral valve anatomy, this rapid movement of the annulus. And that was her MRI. And so she does have scar and fibrosis. Unfortunately, she was seeing a cardiologist that was tuned into this. Randy Martin actually sent this case to us from Atlanta. This is very early in sort of now it's more common, this disease topic. People are more interested and more in the room to listen to this. But in the old days, we used to do this with 10 people in the room. That was her valve, a big Barlow valve, papillary muscles. We'll do a valve reconstruction, and we tip, and this is a time where the Carpentier rules generally apply. We do try and really give people a deep line of coaptation, lower the posterior leaflet height, and lo and behold, her PVC's resolved. So we'll talk some more about this in a few minutes, but this is important that something's happening acutely when you do valve repair. In certain patients, you see this. It's like magic. The PVCs evaporate. And by the way, some patients, that's all they notice. They don't care about their valve repair. Gosh, I'm not having palpitations anymore. It's interesting. Now, the next step of the journey is to understand that PVC morphology is identified on EKG. You have to have an electrophysiologic partner. We are never going to have the sophistication to be able to look at this and tell you where the location of this is. So you've got to have an EP physician that's interested in it. They actually are quite good at identifying the location. Here's another patient. She's 68, has MR. She's had one presyncopal episode, some palpitations. And here's her Holter with 14% PVCs. And again, on exercise stress, it gets a little more interesting. So she's obviously having fairly complex PVCs on exercise. Here's her echocardiogram again. It's almost consistent, isn't it? Many of these patients almost always present with the same phenotype, the same kind of history and morphology. And here's her PVC origin identified by EKG, anterior papillary muscle. And so again, it's the EKG is the pivotal decision point about could we do something else, another additive procedure to try and prevent this disease. And this particular patient had a hybrid cardiac PET and MRI, and we'll talk some more about that in a minute. But this is important because we documented the scar and we also documented inflammation. And we'll talk about that again in a second. Here's her valve. Again, a big typical Barlow valve. And so this patient will also have a typical Carpentier type resection with sliding leafletoplasty, lower the leaflet. But of course, we'll also do an ablation. And now we're going to we're starting to think about, instead in the operating room, we have the technology, why not try and isolate the papillary muscle? So this was one of the first patients that we did this for, where we went inside and we actually ablated the papillary muscle we'd identified as the location, in this case the anterior papillary muscle, and repaired her valve. And lo and behold, our PVC burden went from 14% to 1%. So the journey continues. Now we're moving into more interesting sort of subgroups of patients. This was a young lady that has all these children, and she has actually a low PVC burden, just baseline PVC burden. On stress tests, it's more interesting. I'll show you that. She's had 2 catheter ablations and came to us for a third opinion because she was told, we're going to follow you now. You're in active surveillance. And we talked a lot about this case because this was one of the first cases where we truly saw someone that had moderate mitral valve regurgitation and a low PVC burden. The stress study we wanted to understand a little better. We also mentioned strain. We pay attention to strain in patients like this as well. So her strain is abnormal. It's not completely normal. That's important. Here again was her Holter, not very impressive. She does have complex ectopy, but here's what her loop recorder shows. During the course of a day when she's very active, she acts actually quite important non-sustained VT, which we thought was more interesting. Again, the MR is not the reason we operated here. It really was this combination of symptoms plus rhythm. And here's her anatomy. Same story. See these big sail leaflets that create the tension. And then in this case, we'll do ablations of both papillary muscles and reconstruct the valve. And we generally do 3 minutes. Sometimes we'll stop at 2 if we have the full thickness. And then the valve gets reconstructed. And now actually, this was her 3-month ILR recording. We actually just did one now a year later. It was 0 PVCs now. And so I do think that this is really quite interesting. We were certainly interested in it. For those of you that want to learn some more about this, I refer you to this review article that we wrote in JACC about arrhythmic prolapse, and this figure really shows the key in terms of having substrates and a trigger and then this modulation and how the 3 of them come together, usually with some sort of adnergic response to create this phenomena. And why is this important? Remember, this nagging, why do asymptomatic patients die suddenly? Why do we have sudden death clinics that people survive from? I think this is really probably an incredibly important part of the journey. I'll just summarize the last few slides, some of our other work. This was an important step for us when we realized there was scar. We started to think what precedes scar. This was one of the first descriptions of PET imaging added to MRI, a hybrid study to let us look at early inflammation. And what we saw was very interesting. And that was that it wasn't just patients that had scar, but patients that had inflammation in the absence of scar. So there were PET positive and LGE negative, which really does give you the sense that you have your ventricles going through this process of change. And this figure really was so interesting when we sort of started to really put the story together, because you see these ventricles, and I don't think anyone's going to tell these patients from a ventricular standpoint that they need surgery. If you're asymptomatic and you show up with that ventricle, you can do it. The guidelines are softer in Europe than the United States, but it's interesting when you do PET in these patients, this is often what you see. No scar, but inflammation. The heart's suffering, and the heart's starting this journey towards scar. And some of these patients are moving toward arrhythmias, and that's really important. One thing we know for sure, and we published early on, was this resolution of the Pickelhop sign acutely. That's probably related more to the annuloplasty than changing mitral leaflet morphology. But my assumption in general, I always find if you can restore normal physiology, normal anatomy, and normal function, that's a good thing. I think that's probably a good thing for these patients that have a high arrhythmia burden. We also published our initial experience with cryoablation, Ahmed El-Ishmawi, against the first author on this paper. And what we were describing is just our early experience with this and how we selected patients and what our ideas were. This really shows the summary of how we do that today. Obviously, you need a multidisciplinary team. We tend to focus on patients that have PVCs with moderate or greater burden, and we want to be able to identify on EKG targets. It's always nice when PET MRI documents that, but that's the most important thing. It's actually very straightforward to do, and I think it's important that they be done in combination with valve reconstruction. The last thing I'll mention is this topic of mild and moderate MR. We're actually quite interested in that. We extended that PET MRI study initially without funding to this subgroup of patients and found something very interesting. Patients that had mild to moderate MR, like the case that I showed you, they have mild to moderate MR, but look at their PET positivity. So again, there's something about anatomy is contributing to this. We don't know, by the way, it could also be volume, it could be stretch, but there's something about mitral valve anatomy and physiology that's creating inflammation in the heart. And certainly some of these patients must be the ones that we observe sudden death in. And I think that when you put all these things together, this is just an example from a single patient. I do think, I don't want non-sustained VT. You can tell me that we don't have enough evidence or enough literature yet to be able to say, do these patients actually die, or are they just risk for non-sustained VT? I imagine that generally I like to give people one disease. If we see an incidence of sudden death in young, healthy people and they also have non-sustained VT, they're probably linked. Demos Pandas presented our data last year at AATS on the impact of valve repair, including valve repair alone on arrhythmias. So, and that's why I said that, remember that valve reconstruction alone will decrease the arrhythmic burden by a significant degree. So I think that cryoablation is just additive. We're now on the next journey, which is we got a large NIH grant basically because of a patient that died, and the congressman set up a funding through the NHLBI, which this was one of the grants that we got. I'll mention this is really, really important, and you can see that we, Maria Turriera, Mark Miller is the EP doctor, and Maria is a cardiologist as well as an expert imager with Zaid Faid. So it really takes a group of people, I think, to do this. This is the study where we're now able to not only do PET MRI, we've also added dodatate to look at macrophage activation in these patients. We have an arm where you're not ready for surgery or your burden's not low, but we can still follow you now serially, including with PET MRI, to see if we can start to understand the progression of this disease over a number of years. And then lastly, if you're having surgery, we're able to do biopsies now, targeted biopsies based on imaging, so we can start to understand what we're actually looking at in terms of the PET positivity and inflammation. So hopefully this study, along with many other investigators, is going to start to try and help put all these pieces together. This is basically where I think we're heading. I think modern rhythm monitoring is going to become a routine part of cardiac surgery in terms of mitral valve dysfunction, perhaps aortic insufficiency. I'll plant that seed. But I think we have to also think about volume loading and stretch, but certainly we need to be very thoughtful about rhythm monitoring in the future because we don't want silent PVCs that people aren't aware of, and we certainly want to know in exercise studies if they have PVCs what that burden is. The imaging story is just beginning. We have to move away from just LGE. We have to start understanding earlier signs than just scar with imaging. PET will be one of the steps. I'm sure there'll be other ones in the future, but that's going to be important. And I do think we're also just beginning to understand which patients might benefit from ventricular or papillary muscle ablation at the time of surgery. But I think all three of these things will become important. And certainly the first two, MRI imaging and rhythm monitoring has to be done in patients that have any kind of symptoms, have the phenotype, and are at risk for sudden death. I think you can't continue to actively surveil patients unless we do that. I'll end with this slide, which is still on my bookshelf. I got that from Magdi when I trained with him many years ago, but he's this whole meeting, honestly, has been an incredible celebration. Ishmael, you're just amazing. You put together the most fantastic meeting. It's incredible, really, and an honor to be here. I haven't been to one of these in 10 years, and I'm going to come back because it was really an honor to be here. You did a great job, and I forgot how much fun it was to hang out with all this interdisciplinary topics. And this is the shoulders we stand on at this meeting. You know, this was one of the real fathers, not only of the field, but the father of the idea of the need for meetings like this. And I think that both this work really represents his philosophy. He operated all day, and then at 10 o'clock or 11 o'clock at night, outside his door were all of us, including me at the time, waiting in line to talk to him about a research project or an abstract. And that's what happens when you marry clinical work and observational with the future of science. And that was the seed that he certainly planted in me, and one of the reasons that I got to stand up here today. So thank you very much, Ishmael. Thanks for that honor.
Thank you very much, David. That was, as always, outstanding, and I don't think anyone in this generation has thought as carefully and critically about the mitral valve and made the contributions that you have. So I think on behalf of all of us and our patients, thank you. Well-deserved honor. We'll now move into the general session, and Dr. Larakis will speak on the status of echocardiography in mitral valve disease.
Good afternoon. Thank you very much. I would like to thank Dr. El-Hamamsi for his invitation to this fantastic meeting in a fantastic place. And also I would like to congratulate Dr. Adams for the well-deserved award, Life Achievement Award for all he has done for cardiac surgery and the surgery in the mitral space. I have nothing to disclose. So, you don't need an imager, cardiologist imager, to tell the surgeons how difficult and complex is the mitral anatomy. And we have today many tools to evaluate the mitral valve, but I would like to focus on what I think is the best modality for evaluating the mitral valve. And I think echo, especially with the use of 3D, transesophageal echo and transthoracic echo, and because of the portability and because you can use in the operating room during the procedure, I think it has a lot of advantages. And as you will see in the rest of my talk, with echo, you can tell about the mechanism of the mitral regurgitation, if it's primary or secondary, ventricular or atrial, the anatomical features of the mitral disease, the location and severity of the disease, to plan and guide the repair or the replacement, and also provide prognostic information. And for the honor of Dr. Adams and his work on the mitral space, I will only show 2 slides regarding the mitral valve prolapse, which is diagnosed with echo, and also with the Pickenhall sign, as well as the dejection of the mitral annulus, provides the risk of these patients for arrhythmias, as eloquently was described by Dr. Adams. And also, I think with the delayed enhancement with MRI as well, with PET, also we can risk stratify these patients. And this disease has stages, and we'll learn more about this disease from the trial that Dr. Adams leads, the NIH trial on this, as he well described. Why echo? Echo, especially 3D echocardiography with the use of X-plane. As you can see here, you can exactly see where the mitral regurgitation is coming. And you can scan the annulus from the lateral, what is the left lateral appendage, to the medial aspect of the annulus, and you can see exactly where the MR is coming, how much MR you have. As you can see here, we move now to the medial space of the mitral valve, and you can see exactly where the MR is coming, so you know exactly where the MR is coming from, and when you go to the operating room, you know exactly what to tackle. And I think 3D echo has been made for the mitral valve because of where the probe sits in the esophagus. You sit exactly behind the mitral valve, and this is a surgeon's view. Basically, as you know, and I'm sure all of you see in the operating room every day, this is a Barlow's valve, which with very well description, you can see the scallops of the anterior and posterior leaflet. You can see exactly where the mitral regurgitation is coming from, and you know when you're going to the OR what you have to do. See, this is another case of P2 scallop prolapse, where you can see the calcium on the annulus, which also provides some risk of the surgery, so are you aware of this? And again, with the 3D multiplanar reconstruction today, you can measure the mitral valve area, the gradient, and many other stuff that I will show you as we are moving forward into my talk. So there are echo LV measurements for timing and prediction of the procedure, as well as for outcomes. The importance, as Dr. Adams said, about the ejection fraction to measure the volumes is of high importance, both the right ventricle and left ventricle, which can tell you the time that you will to time the procedure. Also, the sphericity, LV sphericity index, is also very important, and you can measure it with echo, as well as strain, as Dr. Adams described, very important. And there are studies today that strain LV, mostly in the primary mitral regurgitation, can tell you when to do this procedure, maybe earlier than later, because, as we know, ejection fraction can be wrong. What is moving may be diseased, but you cannot pick it up, but strain can give you more information. And again, for the interest of time, I will move forward, but there's a lot of data about strain and the success of the procedure. Also, quantifying the mitral regurgitation, very important. And this is a different talk by this time, but many parameters, quantitative, qualitative, and most of us use the PISA, but we know the PISA is one measurement at one particular time, but the MR is all-systolic or not all-systolic. So there are techniques today and software that using fluid dynamics that can quantify the flow, and you can give you the regurgitant volume. As you can see here the PISA throughout the systole, measuring the regurgitant volume of these patients. And these are already approved techniques, but we have to see in the future about outcomes following this type of evaluations. MRI also is a way to measure the mitral regurgitation. However, as we know, MRI cannot be done for everybody, and also by the guidelines, it should be done only in patients who there's contradiction between the symptoms of the patient and the mitral regurgitation that you see by echo. Preparing for this presentation, I saw this article again from Dr. Adams' team, and all these all these mitral valve score, complexity score, all these things that are included in here, you can evaluate with echo, so the surgeon can be ready and anticipate regarding how high is the score, what technique to use in order to treat the patient. And there are many measurements, as you can see here, from mitral valve repair to prevent LVOT obstruction after the surgery. You can measure the leaflets, the leaflet length, and the aortomitral angle. All these are things that you can do in the operating room, of course, in planning the procedure, but also in the operating room during the procedure. In the secondary MR, it's very important to characterize the phenotype of functional MR as asymmetric or symmetric. Very important to know what procedure you will do in the operating room and also for the outcomes. As you can see here, in again the surgeon's view, this is a restriction of both the anterior and posterior leaflet, most likely from dilated left ventricle with central mitral regurgitation, symmetric tethering in this particular valve. Also, there are other measurements like tenting height, area, and volume that can be measured today using 3D and multiparametric reconstruction that we can do, and we have data today about this that also they can predict outcomes on these patients. Also, you can see associated lesions. Many of the patients who go for MR surgery and have significant MR, they have also tricuspid regurgitation. And with the multi-parametric reconstruction that we can do today, using 3D, you can measure the annulus, and you can decide if you will fix the tricuspid valve the same time if you do the mitral surgery. And finishing up, this is to say something about the transcatheter therapies for mitral valve. Structural interventions is my passion, so this trial also that is led by Dr. Adams. And in this particular space, the most important is the neo-LVOT, and that's where I think CT has an advantage of this in order to see the neo-LVOT and see if this, what will be the neo-LVOT after you place the valve and predict if you have a gradient due to obstruction, which can be catastrophic. But today, also there are trials that have compared 3D transesophageal echo as evaluated for neo-LVOT, and also we are in Mount Sinai doing a trial using actually 3D transthoracic echo to compare it with the CT. Also, very important for gratification immediately after the surgery to see the result, and only echo can provide this information. This is after mitral valve and tricuspid valve repair. As you can see, no, not at all mitral residual regurgitation. Sorry for the delay in the movies, but as you can see, perfect mitral valve and tricuspid valve repair on this patient, and this is after the interpret procedure. Again, perfect deployment with no residual mitral regurgitation. To complete my talk, I think echocardiography, especially with 3D, is the workhorse for the mitral valve. I think especially 3D transesophageal echo has been made for the mitral valve, and I think it can provide comprehensive evaluation of the mitral valve before the procedure, before the surgery, but also can be used the same way during surgery, taking, of course, in consideration the changes in the blood pressure and stuff that can be happening during the surgery. CMR is an adjunctive, can be an adjunctive for the evaluation of scar. CT is important for the neo-LVOT measurements for the mitral space, and hybrid CMR PET, I think, will be critical, as Dr. Adams said, for arrhythmogenic mitral valve prolapse. Thank you very much for your attention.
So thank you very much for a great talk. So are there any questions from the audience? So if this is not the case, I think, because for the sake of time, we should go for the next speaker. Let me see. Yeah, so the next speaker will be Thierry Le Tournon. He will be speaking about genetics of a mitral valve prolapse. Thank you.
Thank you so much for giving me the opportunity to speak about genetics of mitral valve prolapse, and I don't have any disclosure regarding this presentation. Okay, so we have to distinguish between syndromic mitral valve prolapse and non-syndromic mitral valve prolapse. And in syndromic mitral valve prolapse, there are a lot of genes that we identify now with arthropathy in most cases, such as the genes involved in the TGF-beta pathway for the Marfan syndrome, the Lloyd-Seed syndrome, and other diseases. But you have also genes that encode for collagen, different types of collagen, for elastin, for ATP binding cassette protein, or for an enzyme involved in proteoglycan synthesis. The most important information here to remember is that you have to search or to look for a syndromic mitral valve prolapse by looking for a syndromic feature in each patient with mitral valve prolapse. So I don't go to the details of the different syndromic feature, but it's not very difficult to look for the main syndromic feature. And you have also to question the patient for a family history of aorta disease, aorta or arterial aneurysm or dissection. And if you have some signs that are in favor of a syndromic mitral valve prolapse, you have to refer the patients for genetic testing. So most of mitral valve prolapse are non-syndromic or isolated, and you know perfectly now the main phenotypes, which are the myxomatous one, with elongation and thickening of leaflets, mitral annulus dilatation, mitral annulus disjunction, and elongation of chordae tendinae. And the other one is the fibroelastic deficiency type, which occur later during the life. Generally, most of the scallops are quite normal, and you have one scallop which is thickened and elongated, generally the P2 part of the posterior leaflet. When mitral regurgitation develops in FED, it is related to caudal rupture in most cases. So on a genetic point of view, we now know that mitral valve prolapse is a familial disease, inherited, and you can see 50 to 60% of recurrence of mitral valve prolapse in families of a proband with MVP. So when you want to elucidate the background, the genetic background of a disease, and here of mitral valve prolapse, you can have two different types of approach. The first type is the familial approach, which require a large pedigree, at least 3 generations of patients or of individuals. And with the familial approach, you will be able to identify rare variants with a strong or causal effect. The other approach is the population approach. You need a lot of people here with mitral valve prolapse, and you will be able to identify frequent variants, but with a weak effect. So the first gene identified was the filamin A gene, which is located on the chromosome X, so with a specific inheritance pattern. And filamin A is involved in mechanotransduction, which makes sense to the development of MVP. The phenotype is very unique because it associates not only a mitral valve prolapse or mitral valve billowing, but also a paradoxical dominant aspect in diastole or restrictive motion or opening in diastole. Chordae tendinae are short. There is no MAD in our experience, and there is often polyvalvular involvement in this kind of MVP. Indeed, we were able to describe frequent bicuspid aortic valve in patients with filamin A mutation. More than 10% of patients with filamin A mutation or pathogenic variant have a bicuspid aortic valve of different types, and you can also have other types of aortic valve involvement, such as restrictive opening or closing, and also aortic valve prolapse, so a very complex disease. The second gene identified so far was the DAXUS1 that can cause mitral valve prolapse of myxomatous phenotype. In a collaborative study, we were able to identify 3 missense mutation or variants in DAXUS1. DAXUS is located on the chromosome 11, And DAXUS1 pertains to the superfamily of cadherins. Cadherins are involved in cell-cell coupling and also in cell migration, so it makes sense also for the development of mitral valve prolapse. The third important causal gene was DZIP1, identified in a large pedigree from the Boston team, and this family or this pedigree was studied by Francesca Nesta, dealing now, that you know. And the DZIP1 is located on chromosome 13. The phenotype is also myxomatous mitral valve prolapse with posterior or bifid prolapse or billowing in prodromal forms. So in this large family, there was one missense mutation in DZIP1, which is a primary cilia gene. And in a collaborative work, we were able to study cilia genes in patients with MVP based on a GWAS approach. And so, surprisingly, there was an enrichment of MVP associated with cilia genes. In addition, we were able to demonstrate that filamin A and DAXUS1 pathogenic variants impair also the primary cilia function, suggesting that these cilia or primary cilia is important in the development of some types of mitral valve prolapse. So on the other hand, we can have a population approach with the genome-wide association study. Here, a large genome-wide association study with around 5,000 people, patient with mitral valve prolapse, compared with more than 400,000 controls. And as you can see here, we were able to identify 16 genetic loci associated with the development of mitral valve prolapse. And these loci are associated with different biological pathway. First, the TGF-beta pathway. So it makes sense because there are a lot of syndromic mitral valve prolapse associated with causal genes or causal mutation in the TGF-beta pathway. But you have also genes associated with cardiomyopathy genes and finally genes of the cytoskeleton. So my last slide, a few words about arrhythmic mitral valve prolapse. What do we know about this specific entity on a genetic point of view? We know that we can have an association between arrhythmic mitral valve prolapse or mitral valve prolapse and an inherited rhythm disease. So you have to know that because by chance you can have both. Here, a patient with mitral valve prolapse and long QT syndrome. You can also have an association between MVP and an inherited or not cardiomyopathy disease. Here, a patient with a lamine variant, which lead to very severe dilated cardiomyopathy, conduction disorder, and frequent sudden death. And finally, you can have a pathogenic variant that can lead to MVP, cardiomyopathy, but also rhythm conduction disorder, and it is the case for HCN4 gene or PITX2 genes with left ventricular non-compaction, mitral valve prolapse, atrial fibrillation, sinus node dysfunction, and prolongation of QT that can lead to or favor the development of life-threatening ventricular arrhythmia. So to conclude, genetics of mitral valve prolapse is still a work in progress. A few rare causal variants were identified and can lead to MVP, but we can estimate that only 5 to 10% of MVP are associated with causal variants, and in most cases, the genetic background is probably polygenic with several its loci that can lead to MVP. On a pathophysiological point of view, genetics demonstrated that the TGF-beta pathway is involved, mechanotransduction also is involved. The primary cilia function is probably important, and you can also have myocardial development genes. Finally, don't forget the double hit theory. In arrhythmic or not mitral valve prolapse, you can have an association by chance, but you can have also the same genetic defect that can lead to MVP and cardiomyopathy or an inherited arrhythmia disease. But the most important type of genetic defect that you have to identify when you have a patient with mitral prolapse is to look for aortopathy, like as I told you, because there is a consequence for the management of patients. Thank you very much for your attention.
Thank you very much for the presentation. Any question from the audience? Dr. Adams?
It doesn't work.
Jerry, let me just ask you two things. One is about about anatomy. I noticed I've been in 2 sessions with you. You're teaching me things I don't know. You know a lot for a cardiologist. I'm very proud of you. What do you think about anatomy of the mitral valve? And what I mean by that is that does this genetics have an impact on indentations versus clefts? Most patients with degenerative mitral valve disease, many of them have false commissures. In other words, they have 2 leaflets. You can label them with Carpenter's classification, but in reality, P2 is a separate scallop. There's no connectivity. That was a concept Frank Wells always used to push, that the anatomy was driving forces that then over time caused chordal elongation or rupture. And that the textbook drawing where you have a single segment with little indentations, not false commissures, had different tension. Do you think that has an interplay with genetics, or they come together like the double hit? What do you think?
Thank you very much for this very interesting question and important question. We don't have a lot of information about the relation between genetics and anatomy, or this kind of feature that you describe. But we know that between the different genes, we can have different types of mitral prolapse. You have seen some genes are associated with typical myxomatous mitral prolapse, other genes with intermediate phenotype, and I didn't show you, but we identified also another gene which is associated with the FED, and so it is new information, because FED, we often think it's degenerative, just a degenerative disease, but it is not. It is a full spectrum, as you described in your paper in European Heart Journal. And so when there is dystrophy, probably there is a genetic background, and we will have to go further to identify the relationship between genetics and specific anatomic details, as you can explain.
One more quick question. What is this? What are your theory about the relationship between moderate aortic insufficiency and mitral valve regurgitation? So common that we see patients that have non-rheumatic patients that have some degree of aortic insufficiency at the same time. Why do you think? What do you think is behind that?
You are anticipating my next work. So I think it is very interesting, but there is not a lot of data. In Plenary patients, we have both mitral valve involvement and aortic valve involvement, and you can have both mitral regurgitation and aortic regurgitation. Aortic regurgitation can be a restrictive pattern or can be a prolapse pattern in filamin A. And I will be very interested in performing genetic testing in patients with true dystrophy, aortic regurgitation, but without clear aortopathy. I don't know what is the etiology of this kind of disease. And in some patients, there is an association with mitral valve prolapse. I agree with you.
Quick question.
Thank you very much for the very interesting presentation. My question is actually to you and Dr. Adams. With what you said about the genetics with arrhythmic mitral valve prolapse and early identification of inflammation, do you think there would come a day where we would identify patients with arrhythmic mitral valve prolapse who would benefit from correction of the mitral valve prolapse and annular disjunction rather than wait for mitral incompetence and scarring?
With genetics or without genetics?
Probably with a combination of both.
I don't know, really. I don't know at this time. I think it's a very interesting question because we don't know if we have to repair these patients or not. So it is beyond the topic of beyond my presentation right now. But I think it would be very interesting. In the recent paper of Francesca Deling, she didn't find an inheritance of MAD in the pedigrees she examined in a very recent paper. I think 23 pedigrees, different pedigrees, and she didn't find a close inheritance pattern of MAD. So I don't know if there is a relationship with genetics or not, or if it is just different expression of the same genetic background.
Yeah, Francesca's here. I don't want to speak for her. The interstitial fibrosis, it was another layer of this complexity of what's happening to the ventricle in this condition. And I think we can't just say that, well, it was a different pattern of inflammation, but it was inflammation. And I think it does precede scar. And I think that your question, I think, is actually really interesting because I do think we're heading there. Now, the first step is we have to do incredibly safe, perfect mitral surgery. We're almost there. We don't have a 2% risk with mitral valve surgery. If there really is a 2% risk of sudden death, let's say it's 1% or half of 1%, then you've already beat the odds because we know you're decreasing the burden of arrhythmia. So the onus is on surgeons. They have to do a good job. But we have to have, again, the multidisciplinary team. We've got to continue to rely on real expert imaging evidence to help us understand it, real electrophysiology monitoring. But I think that's where we're heading because it does not make sense to leave someone to progress to ventricular dysfunction. I know I don't want fibrosis in my heart if I don't have to have it. I mean, as I always tell every patient, because they're all asymptomatic. They come, they're 60. Mark knows this. He has this discussion every day. They're 47. I feel great. I'm running 3 miles a day. Why do I have to see you? And you're always trying to explain to them because you need your heart. If you want to blow out your 86th birthday candle, there's 46 years to go. It's like an investment in your house. Your roof might stay dry, stay up for 3 more years, but if it's not going to last 20 more years, we all change it at 3 years. And I think that this is where we are heading. I think that we're going to get there in aortic insufficiency too. That'll be another whole discussion, but I think we're going to head toward treating diseases that we identify are damaging the myocardium at the early stages. It's just the next progression. How did we get to doing asymptomatic surgery? Because we were trying to protect the ventricle. As surgery gets safer and more predictable, we'll continue that policy of not letting your ventricle get damaged. That will keep people from dying from valvular heart disease.
So thank you very much for the nice discussion, but I think we need to move on for the sake of time. So let me introduce the next speaker, Vinod Turani, who is a cardiac surgeon, but also doing transcatheter therapies, and he will deal on the current technologies and future technologies for transcatheter mitral valve therapies beyond transcatheter edge-to-edge repair.
Great. This is a little bit more of a show and tell more than anything else. So it'll be kind of an interesting, kind of fun talk. These are my disclosures. So right now for TEER, the toolbox that we have is the MitraClip and the Pascal. The MitraClip is approved, at least in the United States, for both functional and degenerative mitral regurgitation. And the Pascal is approved for degenerative mitral regurgitation. There's the Pascal 2F trial, of which myself and Brian Wisnan are the 2 national PIs for this. And we are almost finished with enrollment for the 2F trial. Hopefully that'll be done in the next couple of months. And then we'll let you know what the results are for the Pascal for functional mitral regurgitation. And over the years, we have seen a reduction in MitraClip residual mitral regurgitation. And over time, and even though surgery is 80% of my practice and catheter is 20% of my practice, this is still the results, if done appropriately, does show good reduction in mitral regurgitation. This is what we call the mitral universe slide, and what you'll see that all mitral valve surgery done in the United States is the top blue line. And I've got data that's going to be coming up shortly in the next month or so, which will go all the way through 2023. So this is through 2021. I'm getting that data that'll be forthcoming in the next couple of months. So all mitral valve surgery in the United States was roughly 20,000 cases. You can see that through 2021, mind you, this is a couple of years behind, mitral clip was the fastest growing procedure. I'm not saying it's the right procedure, I'm just saying it's the fastest growing procedure in the United States. Isolated mitral regurgitation, mitral repair is in yellow, and you can see there are roughly about 10,000 odd cases. I just want to give you a glimpse of what's coming up for mitral regurgitation using the next two slides for TEER. There's a repair MR trial, which is near completion of enrollment. This is for intermediate risk patients who have degenerative MR, randomized to surgery versus catheter valve therapy. I actually did a patient last Tuesday before I came here to Egypt that was converted to open or was randomized to open surgery. I can tell you, David, you'll find this interesting. I actually thought about you when I was doing this case, because if he had gotten a TEER, I'm positive, I'm 1,000% positive he would have had more than moderate MR, because he had a very large calcified posterior leaflet. I ended up putting a 36 band in him. No, I'm sorry, a 38 band, resected the entire P2, and did a P2 resection. I actually had to do P1, P2 cleft closure and a P2, P3 cleft closure of the residual resected posterior leaflet. It was that destroyed. And I'm positive, that patient, luckily for the patient, went to the randomized arm. It could have gone to a clip arm. So it'll be interesting to see what the results show for this. The primary study is a NIH-run study. It is low and intermediate risk patients being randomized to clip versus degenerative therapy. And we're fortunate at Piedmont to be in the top 7 or 8 sites for both of these trials. This is the Class 2 trial that I mentioned to you. And that really ends the primary MR pathway. And for right now, for Piedmont, because we have a lot of trials, this is really the pathway that we take for patients who have primary MR. The guidelines for DMR really do not have much TMVR. You see it's the far left-hand corner, and that's for high-risk patients across the board for DMR. FMR is where I'll spend a majority of the remaining part of my talk. And you'll see on the right-hand side at Piedmont, this is our pathway for FMR. And on the bottom right-hand side, you'll see all the research trials we have. So right now, when I see a patient for FMR, a lot of these patients really potentially go into these research trials, all the way from Alta and Circle and Innovalve, Highlight, Sophia, Intrepid, and Tendyne. I have 6 or 7 different research trials for FMR, and we'll go through some of those. Where do you see transcatheter therapy in FMR? You really don't see it much at all. You see it in the bottom, where at the bottom it says catheter edge to edge. That's based on the COAP trial, and it's a 2A evidence. So again, not much for repair in the transcatheter arm for FMR. I thought it'd be a glimpse just to give what we did in 2024. We did about, when it comes to transcatheter, not surgery, but catheter, which is my talk, we did 120 mitral clips, but we also did the Sapien and 35 Sapien and surgical mitral valves. We did Tendyne, Intrepid, Pascal 12, High Life, Sophia, Encircle, and Twist. These are all the toolbox that we have to work at one institution, so it gives us a good breadth of what's going on. For sake of time, when we look at these patients for especially FMR, we look at these 3 things. We determine the risk of the patient, the etiology patient, and whether their trial are commercially available. So we spend a lot of time on the research. All patients get a transthoracic and a TE, a cath, a CT scan that's gated specifically towards the mitral valve, MRI if their EF is less than 40 to 50%, and potentially PFTs just to look at their risk profiling. And I think that there isn't a ton of data on this, but I'll show you at least some of the stuff that we have going on. The Tendyne TA, which is it's available in Europe. This will be the first transcatheter valve probably later in the summer will get approved by the FDA, as far as I understand it, for mitral annular calcification. And here you can see a patient who has almost no residual mitral regurgitation, and this is something that's coming forward. We'll be presenting the 1 year for Tendyne TA and the MAC arm for myself and Paul Saraja, we're the PIs for that arm. We'll be presenting that probably at ACC or TCT, either this year or next year. That is the current data that the FDA is reviewing for approval of Tendyne in the United States. The Intrepid was a transapical platform. It has now abandoned its transapical pathway and will be strictly in the transfemoral pathway. The results for this have been outstanding. In fact, next Wednesday I have 3 transfemoral Intrepids to do in the cath lab. So it'll be very interesting. I know we have 3 approved. I think we're going to try to do all 3 in one day as part of my Wednesday, one day in the cath lab. And the results have been spectacular with these patients. And it's purely transeptal with a TE. And again, FMR patients that are considered with severe MAC or those that are considered very high risk for surgery. This will be the first, in my opinion, FDA-approved transcatheter valve, transeptal valve that's being performed, and the trial has been completed. I was on the steering committee of this trial, and it is now in the pathways for the FDA for approval. And my guess, again, I have no complete knowledge of this, but my guess is that by next year, this will be implanted as a commercial product in the United States. Again, purely transeptal. The other valves that I thought at least I would show you a glimpse of, just for the sake of time, this is a high life. We were fortunate at Piedmont in Atlanta to be able to do the first in the United States. And here you can see that you're able to go through the aortic valve, encircle the entire valvular apparatus. And after you encircle the valve apparatus, you're able to place a holding ring that allows you then to come transeptal. This got some challenges with this, but it also works very well when it works well. Sometimes getting around the valve apparatus has taken less than 30 minutes, but it's also taken me and the cardiologist an hour and a half. So it is very variable if you're going to catch all the cords or not. And here you can see the first case that was done in the United States. It's myself and 2 of our valve cardiologists. On the bottom left-hand panel, you can see the 3 of us. I'm in the second position. One of the cardiologists is in the first position. We now have completed the valve. You can see the ring that I was talking about is in this location here. You can't see it. You can see the ring, and then you can see the valve that's been deployed. Really no mitral regurgitation with this. Probably my favorite TMVR pathway or device is the Sophia product. It's from Abbott Life Sciences. And we're happy to have done the first case in the United States, but also the most in the world. And this is it's by itself, so it doesn't hold on to the apex, doesn't hold on to any type of lasso. Here's a 74-year-old patient who was in a walker, class for heart failure, end-stage renal disease, pulmonary hypertension, CATS is non-significant CAD. And you can see the calculated STS score for this patient was nearly 15%. That does not include his frailty of not being able to walk. And here you can see myself and 2 cardiologists. You can see I'm turning the knobs there. The red knob that I'm turning is now slowly, under no pacing, it is deploying the valve. The valve is now being deployed on the entire LV side of the valve. And as I continue to turn, the cardiologist is using his hands to make sure that the valve stays parallel and right through the mitral valve. And here, as I continue to turn it, it is completely deploying, again, with no pacing. And usually this procedure can be done in somewhere between 60 and 80 minutes. Patient is intubated with a TE probe, but does not require any other incision. And as you can see, as I've kind of been talking, this is real time, not sped up. We're almost finished with the deployment of the valve. So pretty remarkable outcomes with this. We are now, should be starting the pivotal trial, hopefully early next year. Myself and will be the cardiac surgery PI for this trial. And here you can see the results for this patient with almost 0 mitral regurgitation. This was the original early feasibility study, and we'll be moving forward to our pivotal trial. Just 2 more quick slides to show you. One is, or on the devices, one is the InnoValve. This has not been bought by Edwards Lifesciences. We just did a case. I did a case 2 weeks ago with this device. This will be the 3rd that we've done. You basically come transeptal. You're able to go ahead and flip the cords, and as you do that, once you have the entire chordal structure, you release the valve and you're completed. The case that we did 2 Fridays ago, it was a total of, once we were able to puncture the skin with the device itself, under 30 minutes we had the entire valve deployed. The patient went home after 2 days. The Alta valve is something that we were part of the early feasibility trial, but we actually did not go into because of the device price. Our institution could not come to agreement with the company, and so we will not be doing this valve, but it completely fills the LA. There are a lot of challenges that we have with the TMVR, and I won't go through those, but there are many, such that about 80% of patients are screen failed. 80% of patients are screen failed for any research trial in the United States. This also happens. This is a patient that I operated on. By the way, this was a very high-risk patient that went into the trial. And we as surgeons have to deal with this because now all of a sudden I have a high-risk patient that has this. And now all of a sudden that a high-risk patient doesn't become high risk anymore. And so I operated on the patient. And he ended up doing well. He went home after about 5 days. I just operated. He was a redo. I operated on him. He did fine, went home. About 6 days actually post-op. So my final thoughts on this is that innovation, the main management of mitral disease are increasing dramatically. Trials are underway for repair in low and intermediate risk for surgery. These technologies are progressing slower than TAVR, but I do believe that this will be an increase in the next 5 years as 2 devices will be approved in the U.S. this year and next year. And quite honestly, I think we have to work together with cardiology, not further apart, because somebody has to make the decision-making for this, and it's got to be the right patient at the right time, and we need to make that decision together, not separate. Thank you.
Thank you very much, Dr. Thurani. I think we postpone the questions to the end of the sessions for the sake of time. We move on to the next speaker. It's a pleasure to invite my friend, Dr. Ahmed Afifi. Actually, he's a consultant cardiac surgery at Aswan Cardiac Center. He will talk about the contemporary management disease, rheumatic heart disease. Please, Dr. Ahmed.
Good afternoon, and thank you for the opportunity to present here. I'm going to shift gears to a slightly more primitive way to tackle the mitral valve, but still talk about the contemporary surgical management of rheumatic heart disease. I have no disclosures. Now, what is the problem with rheumatic heart disease? I think is that the Carpuante classification addresses all mitral regurgitation in such a genius way that it encompasses all the forms, and it's also coupled with interchangeable, standardized techniques that have proven the test of time. Problem with rheumatic is that the MR type 3A is one of the most complex valves to treat, and that mitral stenosis is not represented in this. Therefore, in spite of mitral valve repair being the gold standard treatment, it is not the case in rheumatic heart disease, and the patients are condemned to either balloon mitral valvuloplasty or mitral valve replacement. This is because a multitude of factors. First of all, that there's a lot less tissue to deal with in rheumatic valve disease. Certainly less than a P2 prolapse or a Barlow valve, but sometimes even less than a normal valve. The other thing is that it's a diastolic phenomenon, and these are very sensitive. The inflow of blood is a low flow inflow, and it needs to be tackled with care. Third thing is that it's an ongoing disease, and rheumatic disease persists after you repair these valves. And finally is that you can't really tell what's going on by echo. So with a prolapsed valve, you can know exactly what you're going to do once you've seen the valve. But in the case of rheumatic mitrals, you really need to go in and have a look inside just to appreciate exactly what you need to do. Rheumatic mitral valve repair is therefore not standardized, underperformed, and understudied. I start by which patients to repair, although we attempt to repair all of our patients, but when to really fight for a patient, there are patient factors, valve and cardiac factors, and I would say a very young patient with just stenosis or just regurgitation and perhaps a low pulmonary artery pressure would be very well worth the fight to repair this valve. Our concept is to restore diastolic flow. I'll be talking more about mitral valve stenosis because this is a complex thing to do probably. So we start with optimizing the valve opening by liberating the commissures, and I'm going to speak about that, by also improving leaflet pliability, by making them thinner and making them softer. And we increase the leaflet mobility because even a thin, soft valve can be restricted with cords and papillary muscles that are stuck together. And also relieve inflow obstruction across the aortic annulus by preventing overcrowding of mitral leaflet tissue through the cords by opening windows for the blood to pass through and around the papillary muscles by splitting the papillary muscles from each other and from the left ventricle free wall. Now we've used a stepwise anatomical approach that has helped us to perform, but also to standardize and to teach repair of the rheumatic mitral valve. We start by taking annular sutures in all the patients, and then we target the commissures to start with. We go down to the cords and papillary muscles, and then back up to the leaflets. And then we end with testing, and I'll show you how. And then we decide whether or not we need to do an annuloplasty. So the commissures are like the central point of starting a repair for mitral valve stenosis in particular. They can be simply fused, or they can be obliterated or even calcified. And we start by taking sutures to fix the valve, and we define very well where the commissure is, and then we split the cords and the papillary muscles till deep into the ventricle. This is another valve. So we fix the valve with sutures just to have control. We decide where the commissures would be. Sometimes it's easier said than done. And then we split deep between cords and into the papillary muscles. This is another case where the commissure was really calcified, and we had to replace that with a triangular patch and a cord. And you can see on your lower right-hand side after saline testing. Same with subvalvular apparatus. It can start from simple excision of restrictive cords like this. This is a papillary muscle with 3 thick, shortened cords. We start by splitting them into 3 smaller papillary muscles. And then we split longitudinally each of the cords, of the thickened cords, in half, just to achieve softer papillary cords that can help the valve open. A slightly more complex thing is where we take a wedge to transform an amalgamated set of cords into 2 thinner V-shaped cords, trying to mimic what they were like originally. So I hope you can appreciate here how we've turned this very, very thick papillary muscle into 2 thinner cords. And finally, if we're not able to do that, then we do a chordal replacement. But this is much different from the ones we do for prolapse, because this is not to shorten the cord, but rather to gain pliability. The leaflets are usually retracted and thick, sometimes calcified, and we employ 2 techniques, either the peeling, where the rheumatic membrane at a certain stage can be peeled, and we try to do that with every case. Sometimes you're more successful than others. And we use the annuloplasty stitch holes to start our plane of cleavage, and then we make our way centrally. The above is for the posterior leaflet, and below is for the anterior mitral leaflet. Leaflet augmentation. We've been doing that for some time, although currently we've abandoned augmenting the anterior leaflet too much, but we cut at the respective annulus. Especially in the anterior leaflet, we move past the commissures, and extremely important to release all of the secondary cords, otherwise we won't achieve much. When we put a treated patch in the anterior mitral leaflet, but a fresh oblong pericardial patch in the posterior leaflet. And this is testing, and what we do is we test also for diastolic functions by not putting the tester deep into the ventricle, but rather we try and appreciate how much the saline injection can push the leaflet out of the way. It sort of gives us an idea how things would be like. And you can see here that we've not used an actual annuloplasty because we thought that the annulus was good enough without an annuloplasty and to avoid overcrowding. We do that if the annulus is small, if it's normal size with some fibrosis, and in redo repairs. Now, this is a whole case where we've employed the same stepwise technique. An 11-year-old child who had a previous repair when he was 8, and you can see the pre-op with severe mitral stenosis and a lot of incompetence as well. We start by removing the old annuloplasty and putting in the annuloplasty sutures, as you see here, and then the commissurotomy. And we split the cords and go way deep into the papillary muscles. We didn't think there was much to do in the way of peeling. Now here we're separating the papillary muscles from each other, and here from the free wall. There was a thick anterior mitral cord. We made this thinner, and then we removed a speck of calcium from the anterior leaflet. This could be the site of something that was done in the previous repair. And now we cut along the annulus because we thought this posterior mitral leaflet needs a bit of augmentation. You can see we're cutting the secondary cords, and this is what really gives length and makes the posterior mitral leaflet come to meet the anterior leaflet, as you can, I hope, appreciate in the post-op echo. We'll put a long patch that's not too wide. And we test with saline for both the systolic and the diastolic function. So to conclude, I think rheumatic mitral valve repair should be and can be standardized. Choice of patient is very important, but there's a toolbox of tailored techniques that you can use, and if coupled with a stepwise anatomical approach, you can not only perform it, but also standardize it and teach it. Thank you very much.
Well, thank you very much, Dr. Afifi, for a wonderful presentation. I think we are running short of time. I would take two burning questions. Actually, I have one to Dr. David Adams about MAD. Do you have any special techniques to add during repairing a patient with mitral annular disjunction, especially with annuloplasty or slidoplasty? Do you add any?
Yeah, so the most important, what we have gone back to, and we've played around so much with different strategies in terms of limited resections plus Gore-Tex, blending approaches, all the way from aggressive resection and annular plication, and we really have moved back towards sliding leafletoplasty. It lets you put the leaflet back in the true ventricular hinge point. It's very easy to feel. Mark showed a case like that yesterday and said it's very straightforward, and I think it got a bad name. And I'll tell you where it got a bad name. My good friend Patrick Perry wrote a paper, and people read the title. It says, "Respect, not resect," right? But when you read the paper, guess what? 60% of the patients had a resection. So don't be afraid to combine things. The point was you don't have to do. That's where we get in trouble, where everyone says, I only do triangles. I only put in this size band. I only use complete rings. You know, it's a field where you need all, you don't win the golf tournament unless you use all 14 clubs. We saw that last weekend in Augusta. I was there. It was a lot of fun. We gotta have a real toolbox figuratively to do mitral valve reconstruction, but I do think if you have significant annular disjunction, I think relocating the leaflet in the proper hinge point is a good step. And then your annular sutures then reinforce that, and the annuloplasty then stabilizes that. So I do think that's really important. I loved your talk, and I've got to ask you two quick questions. One was about the commissural replacement, which you brushed over, and you were very quiet about it, but that was an incredibly important point, particularly if your goal really is to repair complex rheumatic disease. if I saw it correctly, I'm anticipating you do the commissurotomy trying to get to the soft side of one leaflet and then do a triangular patch in the commissure. You want to just explain that, how you do that? The patch replacement in the commissure?
Sorry, this was a case before we bought the video camera, so I wasn't able to take videos of that. But what we did was, it was a very thick calcified commissure. We tried to take it with a ronger until we finished all the calcium. But what we were left with was a very, very flimsy leaflet part with a fairly thickened but quite healthy cord. So what we did is we put a triangle with the base on the leaflet side and the apex on the cord side, and then we took a pledgeted stitch onto the tip of the cord that remained after the decalcification.
Yeah. The only other thing I'll just comment about is annuloplasty, which is also something that we need to continue to think about and talk out loud about at meetings like this, about in all mitral valve surgery, but particularly in rheumatic patients, because again, I think that the days of the Carpente Classic with a narrow rigid ring to help compress, that's where it all started. I think we don't need that anymore. And you showed that well. If you really needed to do that in a young child, you can put a patch in. But I must say, we favor pericardial annuloplasty in young children. Take a fresh piece of pericardium, fold it in two, not cross the commissures, but stay sort of in the middle of P1 to the middle of P3. And the reason I like that is because when you reduce the annular size, that's an annular compression, you reduce the annular size, you do increase mobility. It does free up the leaflet height a little bit. So what are your thoughts about that? I rarely touch any mitral valve, including someone asked me yesterday about HOCM, where we don't do some reduction to increase mobility. What do you think?
One more question from Dr.
I agree 100% with pericardial annuloplasty for children, and we also believe in that because we think that the side effect of a pericardium from our congenital experience is that it dilates in the future. Then perhaps if this dilates in the future, it will grow slightly with the child. And what you were saying about how it changes the shape of the annulus, I think especially rigid rings are not very good for rheumatic valves because the rheumatic fibrosis occurs in all the different axes. So if we think we want to maintain a certain shape that we know is anatomically correct in a normal person, it's probably not the same. So I would either do a flexible posterior band, whether pericardium or otherwise, or if the annulus is small and fibrotic as the process of rheumatic activity is, then I would probably not put a band at all. Reason being is that no matter how much we peel or make the leaflet softer, it's still much thicker than a normal leaflet. And the annulus is much smaller than what you would get with a prolapsed valve, for example. So what we've seen is a gradient that starts early on rather than being transmitted downstream.
Thank you, Dr. Afifi, for the nice presentation. I have a question to you. How can you determine the size of the needed patch for your posterior annuloplasty? And is there any kind of treatment or preparation for this patch to make it easier for handability during your operation, or you just take it and you put it as a band in the posterior annulus?
On the anterior leaflet?
No, on the posterior leaflet.
No, I'll tell you both anyway.
Okay.
The anterior leaflet, I do it by eyeballing, but when I teach it, I think a very good thing is to take what you would use for measuring the sizer for the annuloplasty, and then you can use that to fashion the exact size, and then you will lose some while you're sewing onto the patch, and this would be a very good size. You need to aim for the patch replacing the whole atrial surface of the valve, and then the coapting surface would be formed with the old rheumatic anterior mitral leaflet. As for the posterior leaflet, I use fresh pericardium, and I start really with a really long patch, and then I go from one side to the other, and then I cut what's left, just to make sure that the patch is not too long, not too short.
Thank you.
Thank you very much. I think we are already late. Before we conclude this session, I must thank all our eminent speakers, all the panel, all the audience. Thank you very much for this wonderful session, and looking forward to see you in the second session, inshallah. Thank you very much.